Welcome to this discussion about counselling and the medical model. My name's Anthony Crouch, and I'm here with Traci Postings and Heather Price. We're all counsellors. We've got a background in counselling and also a background in training counsellors. We've all been programme managers at colleges. And today we wanted to just get together and have a chat about what the medical model is, how it's affected counselling, the kind of implications of recent trends in the sector, and generally think about it both from a personal and a professional perspective. So we'd like to start just with the question of what is the medical model, and each of us is going to say something from our own perspective. From my perspective, the medical model is simply a way of viewing how we achieve change in medicine. And in particular, the argument of the medical model is that change is entirely the product of the treatment. So really, one could think of it as a treatment model. And at first, when you first hear this, it sounds kind of sensible almost. But when applied particularly to the area of mental health and counselling, it's not quite so useful. And the reason is that there's been a lot of work on what causes change in counselling and in mental health. And there are lots of other elements or lots of other factors that contribute to change, not simply the treatment. So within the medical model, the focus is entirely on the treatment, and the doctor, whether it's this doctor or that doctor, it doesn't matter, it's just a doctor. And similarly, the patient doesn't matter, any patient can do, any doctor. The question is the treatment, and the relationship between the patient and the doctor is also unimportant. But as we'll talk about today, these three things are also quite important as well. So,
Okay.
Traci, what's...
And a couple of things I thought of when you were talking, and the first one I thought of is, when I think of the medical model, I think of something being done to someone. It's something quite disempowering in some cases, not in all cases, but it suggests there is an expert and someone who knows what's best for someone, who will then carry out their beliefs on someone else. And often in mental health services that can be without the person's consent. And also I think with the medical model there is a belief that there is a belief in the medical model, and often certainly I and others I know will accept what it says without question, because it is the expert, it is the doctor knows best. And as you were talking, I was thinking about the nature of change. The medical model, without doubt, brings about the most rapid change. Often the change is instant, in that if someone is in an acute state of distress or in a heightened emotional state, a prescribed medication will alter that almost immediately. But it is, of course, only a temporary change. The change wears off. And then, of course, it takes more and more intervention to maintain the original change. So it's almost a false change. And the third thing I thought in relation to the change is, first of all, the medical model makes the assumption that change is necessary, that the person themselves need to change, and that's based on an arena almost of someone has decided what is the norm, what is normal. And then whatever lies outside of that needs to be made normal and needs to fit in with the whole.
So there are external outcomes, really, external to the actual client.
Absolutely.
That's also an important element.
Yeah. I think that's about me for now.
Okay. Heather, what's your perspective?
Well, I think a lot of overlap with what you've both said there. I think when I hear the words medical model, for me, 3 other words come to mind, which is assessment, diagnosis and treatment. And that, for me, kind of sums it up. And I suppose over the years, I've come to believe through counselling there's a lot of value in the assessment and diagnosis. But the treatment, for me, associated with the medical model tends to be pharmaceutical medication rather than anything else. That's what it suggests to me, rightly or wrongly. And like Traci said, that suggests somebody doing something to someone else and not really taking into account that particular individual and their unique needs and wants, their background, their personal history, their personality, their family, their support, all those things. It seems to be quite a simplistic model in some ways.
It's reductionist. It's reducing it right down to the treatment. And all of the research is about reducing it. When you do what's called a randomised control trial, you try and get rid of all those other things I mentioned, which is the differences between the doctors and the differences between the patient and the client and the differences in the relationships. You get rid of all of that and you only focus on the actual comparing different treatments or comparing to a placebo, as in the case of an RCT. And I think that also the other I think there's 2 things that are particularly relevant for counselling. One is that counselling in its origin with Carl Rogers is very much an articulation of an approach that is not the medical model. It's very much against the medical model.
Yeah.
Now, things have changed since then, but certainly Rogers, when he put the client at the centre and said that the client makes the changes, he was specifically challenging the medical model, which is that the treatment causes the change. And I would still argue that that is central to counselling, that the active ingredient, if you like, is the client, not the treatment. And all of the other stuff, including actually the relationship and the techniques and whatever that one uses, are all about facilitating, to use a Rogerian word, facilitating the client to make those changes. Because clients are complex human beings, not bits of inert matter that you bang with a hammer. You have to help them to learn how to change, really. But in the second point, really, was that in recent years it's become, particularly with the notion of evidence-based practice in medicine, the pressure, there's almost a sense from within the field of counselling that there's a big pressure to become more and more medicalised, as it's almost as if the pharmaceutical companies are trying to take over the field of mental health, because obviously there's lots of money to be made.
And that's a big factor, I guess.
And in the field of counselling, one is always, it's almost that we're reacting now half the time to that pressure and trying to be scientific and all this kind of stuff, or look a bit like the medical model, as is the case, for example, with CBT, which I respect. But CBT, of all the different approaches, has very much swallowed the medical model. Whereas the person-centred approach, which has a Rogerian, that's Rogers' original approach, is very much not that. It's very much the opposite of the medical model still. Any?
I think when you talked about the Rogerian approach and how that's moved forward over time, I think it really bears witness to that counselling, what it does with the client, whereas the medical model does too. And I think that's just, really worth emphasising.
Yeah, it's the client.
That counselling is relational in a very equal way.
the medical model, the client doesn't matter.
Absolutely.
The only thing that matters is the treatment.
Yeah.
Doesn't
and the
matter.
symptoms
The symptoms, yeah.
that
Yes.
add up. It's a
Yes.
formula.
Well,
if you've got 6 of these, you've got that, and then we look on page 40 and we do that.
Yes,
And the person's lost, the essence is lost. And interestingly,
but it's externalised symptoms. It's you look at the client
Yeah.
and you have, if you like, a kind of book such as the DSM, the Diagnostic and Statistical Manual of the American Psychiatric Association, which is an incredibly influential document and has just been recently published in its 5th edition. You basically have the symptoms written down, and you look at the client and you check which symptoms this client has got, and then you find a treatment for them.
And it's a joke in just about every counselling group that's training as counsellors, that if you go through these checklists, at any one time someone will have most of the
You've got
things
most
in
of them,
DSM, maybe on Tuesday but not on Friday, depending on the mood and what's going on. And so it's not, and because it's such a static thing, it doesn't move the way people move. They don't dance well together.
And that's also, the DSM is also relevant because, as I mentioned, it's just been published in version 5, and there's been a lot of criticism globally, particularly in the UK actually, of one of the things that's happened with this latest edition, which is that it's medicalising grief. Whereas before grief was not seen as a mental health problem, it is now, not grief per se, but more complex grief is now being viewed within the DSM as a mental health problem, which a lot of people have felt is just absurd. I don't know what do you have a special interest in bereavement?
I do have a special interest in bereavement, and I think that's quite worrying to categorise bereavement and grief in that way. Yes, there are extreme cases, if you like, of grief and bereavement, and sometimes medical intervention in terms of medication is necessary, and yet it seems to me sometimes if people are grieving and go to their GP, the main symptom or sign of their grief is that they're not sleeping, and they would almost invariably be prescribed sleeping tablets of some kind, which might help them sleep better, might help them get through a day a bit better for a while, but actually doesn't help them deal with the grief. And that to me signifies the shortcomings, if you like, of the medical model. Yes, give a pill, short-term gain, but actually that person is still grieving. They still need somebody to talk to and to explore why this loss is having such an impact on them, which brings in many other factors. It's not just the fact that they're not sleeping, which is the outward sign, like you were mentioning, outward signs and symptoms, but actually what's going on is in their head, because there's lots of factors to do with their family, the attachment to that person, previous relationships, current relationships, none of which the GP is going to investigate because he or she hasn't got time, but that's not part of the remit.
And I think I have a very cynical view of the pharmaceutical companies.
Well, there's been some scandals in the United States.
Yeah, and yet, bringing things down to very simplistic terms, the pharmaceutical companies are businesses. Businesses, their goal is to make profit. Therefore, if the drugs they prescribed worked, they would lose a customer. And no business wants to lose customers. No business at all, regardless. It's like diet companies. Nobody wants someone to get thin and stay thin. They lose a customer. Whereas if you prescribe something that works and then doesn't work, you've got a captive audience. And I think that's something that's not widely addressed. And especially when you look at what drugs the pharmaceutical companies manufacture the most of, and they're the depressants and the opiates and the painkillers. By far, they're the drugs that sedate and keep people quiet. And
but also people want them. I have to say that
Absolutely.
it's a way of, people don't want pain, and it's a way of not feeling the pain, at least for the
Absolutely.
day. And I don't think I would go that far and see the
I said it's
pharmaceutical
a cynical view. It's a cynical view.
I do think that they are, they're profit-making companies. Their job is to make more profit. What they want are drugs that can compete in the marketplace, and they want to expand their marketplace. And that's what's been happening from my perspective, is that they've been looking to expand their marketplace. Well, they have expanded it way into mental health and into the common mental health problems of anxiety and depression. But for me, that's not, in a way it's like other forms of comfort or drug. You know, it's just a way of taking you out of your feelings for the day, really.
Well, it's
Until you take
fix,
your next one.
isn't it? A quick fix, and we're very much a quick fix society where people want something to happen instantly.
Well, I do feel though that it's a little bit more than that. I think that, in my sense, is that one of the difficulties that the field of counselling and psychotherapy has is that what we talk about is pain, particularly emotional pain, and what we're about is emotional pain, and people are programmed, if you like, genetically not to avoid that. You know, we're programmed. So we are what we're offering is more than, you know, is more than just, you know, not a quick fix. It's actually something really hard, something that's going to be difficult, something that's something that we're not, you know. Essentially, it's about helping people to face pain that they don't want to face, and that's very, very difficult.
Yeah.
The problem is that whilst we as a society don't recognise that, then the quick fix is seen as not just the quick fix, but kind of like the way.
And it begets itself, because if there is a generation that use that method of self-soothing, then it will have to be passed on, because and you know, we see an enormous rise in the prescribing of Ritalin, for example, to children. But if we have a strata of society that's in a semi-anaesthetised state, it's very difficult then to cope with excitable and full of feelings young people, and so it has a snowball effect.
Yeah.
I think we need to recognise. We need to recognise, firstly, that it doesn't work, and the research clearly shows that the treatment model is inadequate. The research basically says that those 4 elements that I described earlier on, that as well as the treatment, there's the doctor or the practitioner, the therapist, the counsellor. So that's the second. Then there's obviously the client, which is actually the most important, the client or the patient. That's the person who's active. And then there's the relationship. Those 4 areas are all important. But actually the treatment in the field of counselling and mental health, the particular treatment doesn't matter that much. There are lots of different treatments that work well. So the whole research to find the treatment has been basically a huge waste of money. And what we need really is to look at how we interface as a profession with society, and how we can explain to people that actually, if you really want to address your depression or anxiety, you've got to work. You know, it's going to be a painful process.
Absolutely.
You can't just expect it to change overnight.
No, it's going to take time.
And isn't part of the counselling process working with people so that they learn how to hurt and learn how to be able to hurt and deal with that?
And cope with it.
I totally agree, yeah. Except that, you know, unless you've been in counselling, you don't know what it's like.
Absolutely,
So that's the problem, that everybody knows what a pill is, and everybody's had some experience of a pill. Very few people have had experiences of counselling or psychotherapy. So it's difficult to, and there's that reticence. I was at a conference recently which was all about client factor, the fact, you know, the client and how we facilitate change within the client. And what I came away from most from that conference was how the research was showing that there's people basically are frightened of counselling. And really they're frightened of their pain.
Absolutely.
Yes, absolutely.
So how do we reassure people? How do we provide avenues that feel safe enough for people to take that step, really? Because once they're in counselling, most people, not everybody, but, you know, most people who go to well-trained, good counsellors and, you know, are matched well with their counsellor, they do have a good experience. Not everybody has good experiences, but again, there's lots of research to show how to help in terms of matching clients with their counsellors, and also in terms of providing feedback during the process and whatever.
And mostly people will say it's been painful, it's been a painful journey, and I wish I didn't have to go through it, but now I've gone through it, I do feel better, and I've got ways of coping that I didn't have before. And that's the returning benefit that, as you were saying, as they've learned to cope, they can use those strategies and tools when other things happen in their lives, whereas taking a pill means they've probably just got to take another pill or more pills.
Yeah.
And I think you made an important point earlier, and it reminded me that it's as if the two shall never meet. There is the medical model and the therapeutic, and I don't think it has to be an either-or situation, because the point you made that medication is necessary to sustain life in many instances. Without it, in a crisis situation, the outcomes could be dire. And so there is a place for the both to come together and work together, because it may well be that medication is right for someone, but there's never that. There's not enough time for that.
I would agree. I agree that there is a place for treatment, very much so. And in fact, the research suggests there is a place, or shows that there is a place. There are lots of different treatments that are equally effective, but the problem is that the medical model is that the focus is only on the treatment, everything else is kicked out.
Absolutely.
And that's where there can't be that's what has to change.
Yeah.
The medical model has to change from a treatment model to a much
A
more holistic one that
Yeah.
recognises the complexity of human beings, that we're not some block of matter. We're very complex. A better metaphor, for example, is like a software. We have software in a computer. You can't, can't put a pill in a computer. We've got to work on the self, and a lot of counselling is about helping the client to do that, to take a look at themselves, to get, which they don't, people don't normally do. It's an opportunity to take a look at yourself in a safe place with another person who's done this kind of thing. Get to know your feelings, get to know yourself, get to know how to deal with the anger that you might be focusing on yourself and feeling depressed about, or whatever.
And actually to learn, most importantly, that there's nothing wrong with those feelings. That there is this accepted bunch of feelings, that if you're happy and kind and patient and loving and gentle, you're okay. But if you're angry or envious or hating or raging or in despair, there's something very wrong with you. So you need to get rid of that bit of you, and we'll have the nice bit. Thank you.
Damping it down.
You've given a very good example of how we split ourselves in two, and really counselling is about learning to be one person, not a split person.
Absolutely, and the medical model tends to demonise the part of ourselves that we may not like. The shadow side, the darker side, that's what's sedated often.
In fact, there was some research on client-defined goals, or what their clients wanted out of the counselling. And one of the things, what they wanted out of it, but also what they found valuable afterwards. And one of the things they said about the experience was that they actually found staying with their pain valuable, which obviously doesn't fit at all with the medical model of mental health, because the whole point is you've got symptoms, get rid of them. That is it, really.
Or you have a feeling, get rid of it.
For some people, it was actually of great value to finally stay with their feelings.
Absolutely.
Well, and for some people, that hour a week is the only time where they can cry or be angry or whatever it is that they're feeling, because they're not allowed to do that at home or work or whatever. And so it's a great relief and a release to have someone to talk to and let their feelings out and be angry or cry for an hour or whatever it is they want to do, and that be okay.
And accepted.
Giving that permission.
And understood.
Any other thoughts really about how, because I think what we've done here is we've talked about our own perspective. I mean, obviously, one of the, we haven't got somebody here who's arguing on behalf of the medical model. So let's put that on the table. That's not what we're offering today. What we've looked at today is our understanding of the medical model and the different elements of it that we've highlighted. But also how it contrasts with counselling, what counselling and psychotherapy have to offer. I said something about the fact that it's what we're saying to people is, you need to take a look at your pain and work through and on it, particularly your emotional pain, and that's difficult. Have you got any thoughts about how, because the pharmaceutical industry has an easy sell, really, doesn't it? Take a pill and then you feel better. And I'm not saying that's. I agree with Traci that there is a place for that sometimes, because sometimes people can't look at their pain, or they need to get ready to do that.
Yeah.
Really.
It's a hard act
they need
to
to sort
follow,
out
though.
aspects of their life, perhaps, before they can look at their pain. I mean, that's often the case. But in terms of how we, engage with the world, really, how is there any thoughts about how we might?
Yeah, I think it's a strange thing, because in my experience, people that have had counselling sessions and been through a lot of pain in those sessions and then feel better, kind of don't want to relive that or advertise it, or they're perhaps quite happy to say, yes, I had a good experience, but it's almost like they don't want to go back and touch that pain, so they don't talk about it too much. Which actually is difficult for us, because actually what we want is for everyone to go out there and sing and shout and say how wonderful it was.
That's true. And also there's still something about, you're a broken person or something like that, if you've had to go for counselling. There's a stigma.
And sort of,
A lot less so.
yeah, there's still that slight association
So
with
people
shrink and the Americanisation of...
People are secretive about the fact that they've been for counselling, even though they may have found it incredibly valuable.
Yeah, absolutely.
Because they're frightened that other people are going to think badly of them.
Yes.
Yeah.
Now that doesn't really help at all, does it?
No.
And you'll be judged as having failed or
It's
not
actually
being quite right.
It's incredibly courageous. In fact, it should be a kind of mark of courage that you've been for counselling and psychotherapy,
Yes.
rather than taking another route such as a pill, really.
Yeah.
And most people out there don't have the courage to do that, from my perspective. And that's why they don't do it, is because it's very, very hard.
Yeah.
It's like climbing, to really do it in depth, it's like climbing a mountain, but that mountain is a psychological mountain. It's not just climbing the mountain, it's also going down into the pit.
You're selling it to me, Anthony. Good job, I've already journeyed it a bit and know it's worth it.
Well, it's a very hard sell, basically, isn't it? That's the problem we face. And the trouble is that, from my experience over the last few years, rather than be who we are as a profession, we are unfortunately moulding ourselves around the pressures of the medical model and the National Institute of Clinical Excellence and all of this stuff. We are, rather than kind of standing firm as who we are, this is actually it. It's hard. It's about pain. It's not easy. And kind of emphasising that, we're trying to kind of be a bit more like, scientific medicine, really, and show that we're... And really, I think it does, from my perspective, it comes down to it's an incredibly easy sell. Take a pill and you'll feel better.
Yeah.
And we're so different.
And yet counselling does draw on the old values, in that if you really want something, you work hard for it and you apply yourself, and it's difficult. It's not walk into a job, get a load of money, buy a house and live happily ever after. Years ago there'd be an apprenticeship and there would be a period of learning and hard living until the rewards started to come. Whereas with the medical model, you get the rewards first of all, but then you pay. So it's a bit like the medical model appears to me more like a credit card, that you get what you like to start with, but there is a price for that. There are consequences and quite terrible consequences in some cases.
Well, from very early on, actually, from the age of 19, I felt quite strongly that there was a lot of human suffering that was unnecessary. And that's really what's driven my life, that original kind of vision, that a lot of psychological suffering was unnecessary, and that's became very engaged in psychology and the counselling, whatever. We could be so much happier, we could be so much more, we could reach so much for our potential as human beings if we really became much more psychologically literate. If we engaged with ourselves in a fundamental way, as societies, we could transform this planet. That's my perspective. But whilst we remain illiterate, really, wandering around the world, not really understanding anything about ourselves or our feelings, or whatever, because we don't give them any time and because they are painful.
Trapped inside ourselves.
We're messing things up. We mess up our own personal lives, but we mess things up on a much grander scale.
Absolutely.
We mess them up in society. Why are we still fighting? Killing people all over the world? I mean, it's kind of crazy.
And starving and suffering. It's such a ridiculous.
We don't need any of this.
No. There is.
We need
enough.
to. I mean, obviously, psychology and whatever isn't the whole.
No.
But I think it's an important missed element. It's whilst we miss it out, it's never going to work. There are lots of other things that need to happen as well. But if we keep missing out, like the software isn't working properly. We need to debug the software first, get it working well.
Go back to the motherboard, go back to where it went wrong and have a look. And although it's a bit of a, it is a bit counselling jargony, those parts of ourselves we don't like, the shadow part, the pain and all the uncomfortable feelings that other people might not like, we project them onto someone else, something else, another country, another culture, and we have to kill it.
More misery.
Without realising that we're simply seeing the part of ourselves that we don't like. And if everyone could own who they were, at least some of the time, then it would be impossible to do those things. It would just become impossible.
Gosh, that's a wonderful thought, isn't it? That could happen. That's something to aspire to.
So, anything else?
I think that's it for me.
Yeah, I think it's just interesting that the point that you raised about, in effect, how can we sell ourselves as counsellors and what we do, which can sit alongside the medical model. And what I'm seeing at the moment is a lot of services being squeezed out there, so there actually is less help for people. They don't know where to go. Even if they've got the courage that you were talking about to actually go for help, they don't know where to go, or they can't afford the service, and then it's a bit too easy to go back to the GP and say, just give me something. So I think we're in that state at the moment as well, which is not helping.
Yeah, it's true that, as I said earlier, that the pressure from the medical model and pharmaceutical companies is causing a lot of negative effects, really, in terms of not only the profession but also the services and the availability of those services. We're not in a, as a profession, I don't think we're in a particularly good place at the moment. There used to be lots of counsellors in GP surgeries and practices, and now there are hardly any. They've all been pushed out effectively by the medical model.
Because it's cheaper and it's quicker.
And also because
in the short term.
But also I do think that it's a lot easier sell to people.
Yeah, absolutely. This will make you feel better.
Yeah. Well, quickly.
Yeah.
And you don't have to do anything.
Absolutely. And it works until it wears off.
Well, for some people it doesn't work. Some people it makes things even worse.
Absolutely.
So side effects that are quite negative, particularly for
And then there's another
men.
drug for the side effects, which will have side effects. And it's interesting charting how different drugs, a drug which is hailed as a wonder drug, a fantastic drug, the cure-all for everything, becomes the problem. So a new drug, maybe 15, 20 years later, has to be developed to address the problems caused by Valium, for example, benzodiazepine. Fantastic for anxiety in the short term. huge dependency issues. And so something has to be found to address and alleviate the withdrawal symptoms, and then deal with the anxiety, which is now much worse, plus a whole
Than
lot
it
of
was
other
before.
things that wasn't dealt with at the time. And around, I think heroin, for example, that was developed to treat morphine addiction, which was developed to treat opium addiction, and now we've got methadone to treat the heroin that was formulated to treat the... And so it's this ongoing saga of having to find a drug to treat the problems that was caused by the drug, and then find a drug to treat the problems caused by the drug. And yet nobody actually looks at the problems and
In
the
the
issues
person.
and the pain the person had before the drug.
Mm. Mm.
So that's a more kind of down note, but I think it's actually appropriate that the profession is under pressure, and so those who find counselling valuable would encourage them to not be frightened of telling other people.
Well, and I think that a big positive is that counselling training is still very popular. People want to train to become a counsellor,
Yes.
and even if they don't actually become a counsellor, the journey that they have in terms of self-development on the way is bound to be beneficial.
Absolutely.
And positive. And so that seems to me a very positive note.
And on its most simplest form, if we move away from theories and approaches and anything else, counselling can simply be that someone's not on their own. And that in itself is such a catalyst for healing, that there isn't the aloneness. They're not in it on their own. There's someone there with them in the darkness. And a pill can't do that. It can't provide that solace.
No.
So that's been, as I've said earlier, very interesting, more so than I was expecting. Only because of, we're kind of immersed in this question of the medical model and counselling, and have been for quite a long time. So it's good to talk about it, really.
Yeah, it was.
And hopefully what we've been talking about may be of interest and value to those who are viewing it. And for those who do have experience of counselling or counselling training and feel that it's of value, I would very much encourage them to get out there and talk about it and promote it in the world, really, because it is a hard sell. So thank you, Traci.
Thank you.
And thank you, Heather.
Thank you.